Hey everybody, welcome back to another episode of DailyDocTalk. I am your host, Dr. Drew Timmermans. I am currently waiting for traffic to die down so I can head home. So I thought I would make a video for you guys. So I know I've talked about this before on Instagram, social media, and in conversations with people when they're talking about any radiating pain that goes down the back of their leg, whether that's sciatica or not. And so if you've been following me, you know that I am a proponent on the fact that not every time someone has pain that goes down the back of their leg is it sciatica. And so I think I said that poorly, so let me rephrase. I don't believe that every time that someone has pain radiating down the back of their leg that it is caused by anything to do with the sciatic nerve. I'm not saying that sciatica doesn't exist, because it does, and you can have sciatica from piriformis syndrome. It can also be pinched by obturator muscle, and that can compress on the sciatic nerve and recreate those symptoms. You can also have sciatica, which is more of a radiculitis, actually coming from the low back, from one of the nerve roots that actually supplies into sciatic nerve. If you're not aware, sciatic nerve is basically just a big collection of nerve roots. And so those nerve roots, as they come off the spine, they can get compressed in the intervertebral foramen that they're coming out of. And you can have symptoms coming from that way. And so those are real things. But a lot of patients walk through the door and they say, oh, I have sciatica. And some doctors just take those patients at blind faith and then continue to treat as if it were sciatica, when that may or may not be the case. And so there's a few different things that we've seen clinically and supported in the literature that can cause pain that radiates down the back or the side of the leg. Some of the things are peripheral cutaneous nerve entrapment of any of the nerves in that area. The main one I tend to think of is the posterior femoral cutaneous nerve. I clearly can't talk today. That's the main one. Your sacroiliac joint, the ligaments surrounding that can cause a referred pain down the back of the leg and can mimic sciatica. You can also have facet joints in the lower back, in the lumbar region, that radiate pain down the back or the side of the leg, similar to the sciatic nerve. And so, those are all the things that kind of go through my head when I'm assessing a patient and determining for myself, if they've come to me with that diagnosis, if they actually do have a true sciatica. Because the treatments, if it's sciatica, that treatment is very different than if it's a peripheral cutaneous nerve entrapment of the posterior femoral cutaneous nerve. Did better on that one. Or if it's the facet joint, or if it's the SI joint. And so the real power in physical medicine, and again, whether that's physical therapy, massage therapy, any of the regenerative injection therapies, the real power in treating a patient's pain at the tissue level. And again, I don't want people hopping on here and saying I'm not cognizant of the biopsychosocial model, because I am. I'm just not talking about that in this moment. Right now, I just want to focus on how we can create tissue changes and help to regenerate certain areas, or eliminate pain signals that may be coming from the tissue. And so, I kind of digressed on that, but the point is I want to, the treatments are different. And so the power in those different types of therapies lies in addressing what is the actual cause or the root of that pain. Put differently, what is the pain generator? When we treat the pain generator, pain starts to improve. If we don't treat the pain generator and we just apply a treatment to a different area that we thought was the pain generator, then it's possible that does not improve. And so I just wanted to spend a few minutes here. I'm going to take this camera, I'm going to zoom it out a book, and I want to show you where these posterior femoral cutaneous nerves are, so that way that can maybe help start to create that framework in your mind of maybe it's not always sciatica. We got everything in focus here. So this here is one of my absolute favorite anatomy atlases. This is Atlas of Anatomy, 3rd edition. This is the team edition. If you want, I'll have a link in my bio for you, or not my bio, under this YouTube video for you guys to see. So I apologize for this focus, but so here we have the back of the leg. We have these superior cluneal nerves, middle cluneal nerves that are kind of coming, inferior cluneal nerves. They're going to innervate some of the aspect of the glutes, and also the superior aspect of the hamstrings, inferior aspect of the glutes. But what I want to focus on here is the posterior cutaneous nerve of the thigh right here. And so you can see that nerve, or the branches of that nerve, piercing out through the backside of the thigh in the hamstring, coming through the fascia that's encasing the hamstring muscles. So when those nerves are pinched by the fascia on the posterior aspect of the hamstring, they can create pain signals that can be worse with certain positions. And so when you think about the way the fascia is going to tighten in certain positions, particularly if you're going to go into any hip flexion, that's going to create tension along the posterior aspect of the lower back, the glutes, and the hamstrings. Think of going down for a hamstring stretch. And so that tightens the fascia in that area. And so if those nerves that are piercing through the fascia are already inflamed because of tight fascia, or the tight muscle as it pierces through, and it's clamping down on that nerve, which is then causing a buildup of nerve growth factor, which is then causing expression of TRPV1, the ion channel, and then you're getting a dumping out of substance P and CGRP, two peptides that are going to be involved in the perception of pain. But also CGRP is partly involved in degeneration of tissue in the area, as well as calcification. So you can think of things like calcific tendinosis. And so if that nerve is already inflamed because it's pinched, and then you go into certain positions that tighten that fascia more, that could worsen your pain. And so that could present as when someone goes to bend forward, they have pain that shoots down the back of their leg because of those pinched nerves. That could mimic sciatica. And so for clinicians and therapists as well, it's important to note that when you're doing any of the orthopedic tests like straight leg raise, for example, you're bringing that hip into flexion, and you're passively tightening up and creating tension in the posterior aspect of the hamstrings. And again, you could worsen that peripheral cutaneous nerve entrapment. And so if it's between that 30 to 60 degree window that we typically look at for a positive orthopedic test for a bulging disc, which could be contributing to sciatica, then that can confuse you on what the diagnosis might be coming from, or where the pain generator may be coming from. So the moral of kind of this video was just that just because a patient comes into you saying they have sciatica, or if you believe that you have sciatica as a patient, I question you to challenge that diagnosis. I'm not saying it's wrong. I'm just saying make sure that you are solid on that and that you have the supportive evidence behind it to support that. And two, just the various different ways that we can have pain that radiates down the back of our leg, and why it's important to have a really solid understanding of the anatomy in that area in order to understand where the pain is coming from, or to be able to know how to assess where the pain is coming from, so that way you can treat it. And so that gets to our last part, is treatment. And so our typical treatment for this is going to be some form of myofascial work to help loosen the structures in the area. Sometimes that's not enough and doesn't provide any long-term relief. And so some of you may know this. If you're having these symptoms and they get better with the massage and then it comes back after a few days, that could just be indicating that the massage is helping with the muscle tone and the fascial tone in that area, but it's not getting to the root cause of why it's there in the first place. And so you either have to dig deeper or look at a different therapy. And so in those cases, we tend to incorporate the perineural injection therapy, which is an injection of 5%, so a low concentration dextrose, and we inject it underneath the skin and the subcutaneous tissue, but above that fascial layer where the nerves pierce out. And so when we put the perineural solution in that potential fascial plane, we're bathing the nerves in the 5% dextrose, which calms down the inflammation around them, decreases those peptides I talked about earlier, substance P and CGRP, But also there's the mechanical separation of the tissue, which is then going to help with the taking kind of the mechanical stress off of that nerve so that it's not sending out pain signals through the TRPV1 ion channel. So I hope you guys enjoyed this video. I know I got a little technical in some parts, so if you have any questions, hit me up in the comments section below and I will answer them. And if you could, like, subscribe, and share this with all your friends. See you later, guys.